Welcome to YouTube channel Knowledge Base. This is Suresh Venkat, connecting world with innovative experts. Today we have our guest of honor as Dr. Vijay Chakkaravarthy. It's a pleasure to welcome Dr. Vijay Chakkaravarthy. Dr. Vijay Chakravarthy has completed his MBBS from JJM Hospital, JJM College in Davangere, Karnataka. Then he went on to complete his DNB in General Medicine from Vijay Hospital. With a special interest in critical care, he went on to complete a diploma in critical care from Apollo Main Hospital. Then he was awarded an European diploma for critical care. He was a consultant with Apollo Main Hospital. He was a consultant for critical care in Apollo Main Hospital, then a consultant physician in Apollo MRC. He has presented papers in various national and international seminars and is currently heading a critical care department with Upper Samik Kumaran Hospital. Today he is going to talk on myth in ICU. Over to you, Dr. Vijay Chakravarthy.
Thank you. So there have been so many topics about medical that has been discussed in the internets. You take headaches or neurology or the kidney, dialysis, heart problem, heart failure, heart attacks, diabetes, everything has been already discussed. So today we thought we'll discuss a different, which is untouched topic, the myths in intensive care unit. So anytime you admit a patient or one of your relative or your friend is admitted in ICU, you have so many myths and so many thought process come to your mind, especially when an old age patient gets admitted. You may tell that please do not make him suffer, let him go peacefully. Or you might think that it is a overcharge. Why do you need a ICU admission? Well, there'll be so many blood investigations and ventilator. Anyone who goes into the ventilator might not turn around. So there are so many myths in the ICU, and but you have to understand that ICU has saved number of patients and number of people across the world. Anyone who is getting sick will go into the ICU, and anyone who is sick even in the ward, they'll go to ICU and then they'll turn back from ICU, and thereby it progresses. So ICU is one of the very important place. In India, the importance for the ICU is slowly being felt. In Australia, UK, and US, it has been a specialized course for the last more than 2 decades. But now in India, we had recognized that yes, it is a specialized branch that has to be dealt with the specialist and not with another doctor like any other doctor like a neurologist, nephrologist, or a cardiologist. Yes, it is a separate branch that has to be, and separate specialists are there to make or to revive a life from close to death or near death scenarios. So will trace what are the myths and we'll try to break the myths. First of all, first thing, ICU admission is unnecessary. The patient is talking to me and patient is conscious, then why do you need ICU admission? But we have to understand that most of the hospital have, even a 700 bedded hospital or a 500 bedded hospital will have only 10 or 15 bed of ICU, not more than that. Even if their whole hospital is full, they'll have only 15 ICU beds. So the demand for ICU beds is always there. The resources used in the ICU, the health power and manpower used in the ICU is enormously high. Hospital has to invest huge amount of manpower, not the money. It's the manpower who are needed. So much of manpower and the equipments are being used, and just like that, it's very difficult to put a patient in ICU unless they have a very fixed criteria. If the patient is talking and conscious does not mean that he is all right every time. Example, any patient with a heart attack may have many problems related to the heart attack, like arrhythmias or the different heartbeat or inaccurate heartbeats, what you used to tell. they might be they having any time, or they might be having failure because of the low pumping fraction. For all these things they need a close monitoring. And the basic difference between the ICU and the ward here is there'll be a continuous monitoring device with 1:1 nursing care and a doctor who is available 24 into 7. The monitoring device what you see in the hospital, or even in the pictures what you see, you need a continuous heart rhythm monitor, the saturation, the blood pressure monitoring, everything. These are things needed there. So definitely for that you need a ICU care. The thing is that anyone who talks to you and fully conscious is not always normal. They might be having any other problem, electrolyte imbalances and other things also, for which they might be needing ICU care. Sometimes for giving a drug also you might shift, or sometimes for blood transfusion where the reactions might be high, some costly drugs where the reactions might be high, even for that they might shift to ICU. So shifting to ICU or admitting in ICU is not always a thing like a money minded or this. The unawareness is the biggest cause for this. People fail to understand that. Then the second thing is, anyone who is on ventilator, they will not turn around. No, it is not true. Ventilators are given for different cause. Example, one patient might be put on ventilator because of the bad lungs. Till the lungs become better, we have to support his breathing. One is that. Second thing, sometimes the patient might be totally unconscious, like in the case of a stroke. So till he regains his consciousness, we have to support his breathing through the machine like a ventilator till he comes out. So that is also another form of support. Just like how dialysis support a kidney, we cannot doesn't not mean that anyone who goes for a dialysis will not turn around or will not make his life. No, there are so many people dialyzing weekly twice or thrice. So similarly is the ventilator. How dialysis is for the kidney, ventilator is for the lung. It just supports. It does not treat any patient. It's not a treatment modality. It is just a supportive modality where till the lung heals by itself, we can support by the or till any other organ improves, like conscious level. Someone who has a stroke, at least 3 to 4 days it will take for the stroke to reduce and his conscious level to come back. For that 3 to 4 days or 5 days, you might have to put them on ventilator, and once the conscious level is better, might turn around. So these are the things. And not only that, not to forget, most of the surgeries like open heart surgeries or some major surgeries, almost everything involves a ventilator. The patient will be given a general anesthesia, will be put on ventilator, and then successfully taken out of ventilator immediately. So ventilator does not kill a patient, ventilator does not cure a patient. Ventilator is a supportive therapy, just how the dialysis does to the kidney. The respiratory system is supported by ventilator. And the next thing is that ventilator are intentionally used to prolong the ICU stays, even in dead patient or a brain dead patient. No, it is not like that. Usually, ventilators are operated by the specialist in that. Till the conscious level comes, yes, you might be on ventilator, but the criteria to fix a brain dead patient is actually very different. Does not mean that someone who does not move his hands and limbs or who is completely unconscious is brain dead. No, brain dead requires a strict criteria to tell. There should not be any small initiation of cough or a breath also by the patient. There are so many criteria to tell as a brain dead. So that is a myth that a patient is totally unconscious, so he has been put on ventilated and being artificially ventilated without any thing. No, that cannot be done. Brain has its own criteria, so that is again a myth. And next thing, all the ICUs are the same, and hospitals might just create unnecessary confusion. No, it is not like that. How cardiology, if you have to go for a cardiac bypass, or you have to go for an angiogram or a stent, you look for a center which is specialized in that particular thing, like a cardiac. Or if you have to go for a liver center, you want to see a center which has more focus on liver. or the abdomen, or sometimes for chemo you have to go for a cancer suit. Similarly, ICU has emerged a field where it has to be managed by the intensive care people or the intensivist. So you have to search for a place where the specialists are there, and it does not stop with the doctor alone. ICU is not about the doctor. The sisters who are trained in the ICU make so much of difference, and the whole ICU team, which compromises of physiotherapist, a dietitian, a doctor, a nurse, and associate doctors, and then other paramedics also. All these people put on together to give a good outcome for the patient. All these things are essential, which we have been forgetting for so long. And if we can see, most of the problems comes either in the emergency department or in the ICU. The problem between the doctor and the patient, or the hospital and the patient, comes at the level of the ICU or at the level of emergency rooms only, because India have very few intensivists and a few emergency physicians or the specialist in that. So unless the cases are dealt by a specialist who are the most experienced in that field, like critical care or the emergency, the gap is going to be high, because the normal doctor who has just completed the MBBS will definitely not be as sound, or any other people who is going to manage the ICU, like the anesthesia or the general medicine or the pulmonologist, may not have. It's a super specialization. ICU is a super specialization, so it's a super specialist who has to run. So please look out for the place where you have a good team of ICU doctors and nurse, associate doctors, paramedics, and physiotherapist and dietitian. Diet has to be taken care, and the early mobilization, immediately mobilizing the patient with the help of the physiotherapist, knowing the physiologist, everything is also very much needed. And the second thing is that doctors do not tell the prognosis or the outcome when they admitted into the ICU. Uh, Usually, they'll be explaining in a way where everyone can understand. But the problem is that the acceptance of the people, or one problem, it might be the acceptance of the people. It is usually difficult to accept the patient condition at the time when the patient reaches the ICU, or when the relatives are seeing in the ICU. There might be problem in that. Or the second thing, the doctor who are not specialized in this ICU, they might not be able to tell how far the disease can travel, how many days it will take, what are the complications you might be expected. So the misunderstanding between the doctor and the patient, or patient attenders and relatives, might be reduced, because in a day example, a patient comes with a trauma after an accident and he has many rib fractures. On the day one itself, the doctor as a consultant in the ICU might explain that the rib fractures usually it will take some time to heal. Sometimes if there is flail chest, if the chest is moving in the opposite direction, it might be requiring the support of a BiPAP machine or something like that. So we have to predict all the probabilities and the possibilities and the complications which are done by the specialist in that field. When you tell on the day one itself, example, if the patient requires a BiPAP or some form of a ventilator on day 3 or 4 or 5, the patient might believe that, yes, doctor has told me on the day one itself that this disease can go ahead with all these complications. If that was not discussed on the day one or day two, then there is always a misunderstanding between the patient and the doctor, because suddenly they think that suddenly it has come out of the blue. When I admitted, the patient was completely fine without ventilator. Now suddenly he says that he should be put on a BiPAP machine or a ventilator. So you have to expect the probabilities of having a complications, everything. It is done best when you are good in that field, or when you are specially trained in that field. Then next myth what you have is the tracheostomy, where they put a hole in the throat. Yes, many of them, they think that it is better to have the patient on a ventilator than putting the hole in the throat. No, it is not like that. Tracheostomy gives much more comfort for the patient, where the patient might be sitting in the chair. He might be able to even swallow if he is fully consciousness, and except that he might not be able to speak for the initial few days, he might be fully comfortable. It decreases the sedation, because if you are on ventilator, you might require more sedations or anesthesia medications. But and it is easy to clear the secretion on tracheostomy also. So does not mean that anyone who has a tracheostomy is going to feel the discomfort. No, it is not like that. Tracheostomy is much more comfortable than anyone on ventilator or any other things. So then next thing is that there are so many unnecessary investigations they sent on in ICU on daily basis, day-to-day basis. The anyone who reaches the ICU is usually critically ill. Even a small fluctuations in any one parameter might affect the whole organ. Example, any patient who had a heart attack, if they'll be admitted in ICU. Usually, if the potassium level is low, it might trigger irregular heartbeat called as atrial fibrillation. Once the heart attack patient has a atrial fibrillation, they'll go for the flooding of water in the lungs, which we called as the pulmonary edema, for which they will require the ventilator or a BiPAP machine or a diuretic or some form, even sometimes dialysis. So a small potassium value might put the patient on a NIV, ventilator or a dialysis, all these things. So we need to, this is one particular example I give. There are so many other diseases and so many other influences also. So you need a continuous monitoring with frequent of investigations of necessary investigations and blood reports daily. And then why I should be allowed only once a day or twice a day? Why can't I directly sit with the patient? Because the patient will have more confidence when I sit with them. No, usually to avoid the infection from one person to another, because the attenders travel a lot of places and they come from outside, to prevent the infection carried on from one person to another, or from the patient to another family member, or from another family member to the patient, or by the bystander or by the nearby patient. We have to avoid so many infections. So that is why the limitations are there. Second thing, when you have in intensive care or ICU unit, is a place where you require so much of effort from the patient, doctors and the nurses. They will be constantly assessing the function and the parameters. So when an attender is always there, it is not having a full freedom. The mind, it might not be able to evaluate properly in the patient attender fully. So that is why they decrease the number of visits also. But if the patient is having an altered sensorium, if his conscious level is slowly getting altered, or he's restless or agitated, then you might need a frequent visit with the help of doctor. That should be there. So to put everything into one place, yes, ICU is a place where we have so many myths that anyone going into the ICU will be put on ventilator or will be managed even after dead, or they might not come around after ICU. No, it is not like that. It is a place where several thousands and millions of lives are being saved at any point of time. It has to be managed by the intensive care physicians or the ICU specialists, who are super specialists in dealing with those conditions and who are expertise in that. When managed exactly by them, the chances of recovery is going to be very high. Especially we would have seen in the patient of COVID era, where the patients who are managed by the intensive care physicians, they had much better outcome, because they know like ventilator means, they know the best thing to manage a ventilator rather than any other physicians or any other MBBS people. So we have to understand that it is a separate branch and it has emerged in India. Thank you.
Okay, sir. Just one question, doctor. What challenges you face while explaining the treatment process to patient or the caregivers? In the challenges
First
you,
thing,
yeah.
see, ICU is an expensive place. In
Okay.
India, it roughly costs around in a very medium ICU, it costs around 10 to 15,000 minimum. But
Mm.
most of the ICUs is a place where we spend around 20 to 40 or 50, even 75,000 or even 1 lakh per day in many ICUs. So financial challenge is the first thing we have to assess. So admitting a patient in ICU itself, the first thing is the financial thing. Why the patient also might have that, and even the doctor also might think. Second thing is that acceptance from the people, as I told, accepting that the condition is going to be critical. Example, the patient might be having a stroke. He might receive the patient in first 3 to 4 hours, but the stroke does not halt immediately like that. Usually what happens when we fall down, there is swelling of the hand. It
Okay.
usually does not occur immediately after falling down. The
Okay.
next day you see the swelling will increase, right?
Okay. Okay.
But what happens in that is, similarly thing after a stroke or after a brain bleed, there might be swelling of the brain. So when the swelling of the brain peaks after 24 hours or 48 hours, the conscious level will slowly come down. So the patient, what the attenders think, when I brought to the hospital he was fully conscious, but today or exactly after 24 hours or 48 hours, the patient condition is dripping down. It is a natural phenomenon that is bound to happen. The treatment for that is, usually initially it is managed with the injections and IV injections and drips to decrease the brain swelling. If it does not happen, in spite of giving some anti-edema measures by IV injections, the patient has to take him for surgery. So all these things will happen after 24 to 48 hours. As a doctor, if I don't explain you on the day one itself, these things can happen. If I just tell that, yeah, he has a stroke, we are giving medications, let's see how he goes on, the problem will come in the second or the third day, where it is difficult to accept the clear picture of that this is the disease, this is how it is going to progress. It has to be given on the day one or day two itself. That will reduce most miscommunication and the gap between the patient and the doctor.
Thank you, doctor. Thanks a lot for spending your valuable time during a weekend. And despite your busy schedule, you have agreed to speak on Knowledge Base YouTube channel. It's really a great pleasure listening to you. I'm 100% sure the people who watch this video, definitely it will be a great value for them. Thanks a lot, doctor. Thanks a lot.
Thank you so much.
Thank you.